Good evening, colleagues and friends. I thank IS for giving this opportunity to present my case of bilateral discoid meniscus, uh, either resect or repair, for their YouTube channel. So my case is 15-year-old boy who often complained of snapping and occasional pain on deep flexion of his both knees. So he also gave history of injury to his left knee 3 years ago, which he recovered following rest and medications. He presented to us with a history of fresh injury 1 month ago, following which his pain and swelling aggravated and his knee range of movement has been restricted on the left side. The right side, he continued to give history of snapping and pain on the deep flexion. On clinical examination, there is mild effusion on the left side, lateral joint line tenderness, McMurray's was positive, and his range of movement was terminally painful and restricted. The left knee, and on the right knee, there was just joint line tenderness, McMurray's was positive, and his range of movement was terminally painful. On further evaluation, when we saw his X-ray, so his weight-bearing X-ray showed that there is widening of the lateral joint space. So the fibular head appeared to be at a higher level as compared to the normal X-ray. So there was also squaring of the lateral femoral condyle. There is hypoplasia of the lateral tibial spine and lateral femoral condylar notch, and also there is cupping and obliquity of the lateral tibial plateau. So all these findings are typically seen in a well-established discoid meniscus. Ha et al. Have shown that there is a positive predictive value of about 76% in children between 10 to 16 years of age group. So Silverman et al. Have given that there is uh, MRI criteria based on for the diagnosis of discoid meniscus, presence of band between anterior and posterior meniscus in three contagious section, and when the presence of bow tie sign on the sagittal view, and there is a difference in the sizes between the anterior and the posterior horn, presence of complete meniscus in all the sections, and whenever there is an increase in the transverse diameter of more than 15 mm. So based on this, in our case, the left knee showed the typical discoid meniscus. There is an bow tie size seen, and there is complete discoid, and also we could see that there is a signal changes on the meniscus which represent there was a tear, and it was a complete tear, and there was a posterocentral shift. So similarly, on the right side MRI also showed a discoid meniscus, but the tear was not as severe as on the left side. So we all are aware of the Watanabe's classification for the discoid meniscus. It has been classified into complete when there is no lateral condyle is seen and it has a stable attachment, incomplete when some lateral condyle, tibial condyle is seen, and Risberg type where it lacks the posterior attachment of the lateral meniscus, and it is more hypermobile. So Ahan et al. Have given the MRI classification of the discoid meniscus based on their peripheral detachment. So there is no, whenever type A is there is no shift, and in B it is post anterocentral shifting of the discoid meniscus. There is in type C there is a posterocentral shift, and in D there is a central shift corresponding to the loss of the posterolateral corner. So this is a normal treatment algorithm. You can conserve these lateral discoid meniscus as long as the patient does not have any mechanical symptoms. So the patient can present you in early age group or during their adult life only when they have developed a mechanical meniscal tear, so they present you with a pain or locking symptoms. So this is a time where you need to intervene in this kind of pathology. So once you get a MRI and investigation done and confirm that there is a significant discoid meniscus with a tear and patient is symptomatic, so you subject him to the arthroscopy, and there are procedures like you do a meniscal saucerization, and you can do if there is an associated tear, you can either repair the tear or do a partial meniscectomy. Whenever there is an instability, you need to fix this meniscus. So this is our case which shows there is a complete discoid meniscus on both the sides, and this is the right side arthroscopy. So we started reducing the meniscus here. So the right-sided, you need to have a very good aggressive shaver to trim this tough collagen tissue. So you have a very thick meniscus. You can see it is more than 15 mm of width here. So you start debulking this meniscus gradually, step by step. So we were not seeing any lateral tibial surface. So we now are able to visualize some lateral tibial condyle. So you need to have a very good basket punches so that you can take out this tissue. And now you can see that we have started noticing there is a cleavage tear here in the discoid meniscus. So you start trimming this. So it is very difficult to say what is the end point here, but you have to be very patient and try to find the normal tibial surface. So when you have done adequate number of knee scopy, you know that you can, the amount of tibial condyle you see when you put it in the figure of 4. So you should be able to achieve the kind of end result here. So now we see that we are still able to see some tibial surface, and still there is a good amount of meniscus which is present behind. So we start trimming it further. Now if you can even take a smaller punch if you feel like you will damage the or scuff the femoral condyle. So now we see that the cleavage is deep down and there is still a good amount of meniscal tissue present. So now you be little more aggressive and take you can take some more meniscus here. So we decided to further trim the meniscus here. The job is much easier now because visibility is much better here. So now you can see that we are able to trim. So here, after you achieve satisfactory debulking and you have a kind of cleavage here, so you can do a cleavage repair here if you feel that you are comfortable doing that. So you can still debulk internally, and then you can close the mouth with couple of stitches here. And if you feel there is any financial constraint, then we can still, as in my case, so we did a further debulking. Now we can see it is quite stable, and we are able to restore the entire tibial surface now. So this is then you can just do some RF so that you get a good collagen here. So this is the end result. You are able to restore the entire lateral tibial condyle. So this is the more painful side, the left side. So this is the intercondylar notch. The ACL looks good. The medial meniscus was okay. So this is the complete discoid meniscus. So we are not even able to reach any dent or any rent. So it was very difficult to find some entry for your instrument to get uh, some bite here. So you probe it on the, after probing you take your basket punch, try to get a bite in this kind of tissue. And so once you try to get a bite, then you gradually do a debulking of this meniscus tissue here. So you should be very careful about the anterior horn and the posterior horn. So you should try to retain that tissue here. So we started debulking here, and we did a similar debulking procedure what we did on the right side. But here, if you see, there was a tear, and there is a posterocentral shift. So we realized that there is a posterocentral shift here, and then we took a outside in suture to pull the meniscus behind, and then again further started debulking it. So why is it important to realize this is, otherwise you end up taking off the entire posterior horn. So we started again, we noticed the cleavage here, so we debulked the cleavage. We started taking out that. So now we still see that this tear is much unstable. It has flipped into the joint, so we need to stabilize this tear. So unlike the previous side, this tear is flipped into the joint, so we need to definitely repair and stabilize this tear. It is a quite unstable tear, so we took another outside in suture to pull it back, and then we took all inside suture device. We decided to fix the posterior horn with the all inside suture device. So we took a bite with a all inside device. This is a air of striker. It's a good device, very comfortable. So we just took a bite into the meniscus, and then we took a bite into the capsule. So posterior capsule, or sometimes on the lateral aspect, you end up taking into the popliteus tendon. So on tightening, you can see that the posterior meniscus is well shifted back now. So now you can gradually trim the anterior horn. So we started trimming the anterior horn. Now the posterior meniscus is well stabilized. So we try to debulk the anterior portion. Still you can see there is a good amount of anterior meniscus which is left, and also it is unstable. So it is very important here to again stabilize this meniscus here. So we repair this by taking another outside in bite now. So we took another outside in suture for the anterior horn, and all these prolines were replaced by fiber wire. So we did some micro fracture here to produce some narrow stimulation and biologics for the healing of this lateral meniscus. So this is the end results where you can able to see, able to restore the good amount of the lateral tibial condyle. So this is the outcome at the 6 months, and this patient is very happy. He is feeling is pain free and lost, and is doesn't have any snapping now. So the rehabilitation is very important. Any patient who undergoes saucerization can be immediately allowed to weight bear as per their pain tolerance, and there is possibility of early return to the sports in these patients. But the patient who undergoes repair, we all know, have to be protected. So you do a gradual weight bearing and full weight bearing only after 6 weeks, and again we have to be very slow on the rehab and getting back to the sports. So these are the various literatures who have shown that saucerization along with stabilization have excellent outcome in these kinds of discoid meniscus when compared to doing partial meniscectomy or saucerization alone. So discoid meniscus is one of the common congenital malformation of the menisci, and clinical presentation is highly variable. It depends on the type of discoid meniscus, associated hypermobility or concomitant meniscal tears. X-rays and MRI gives valuable information, and particularly MRI helps you in diagnosis and plan for the treatment. So evaluation of the asymptomatic side is also equally important, because most of the time they are bilateral lesion. So whenever there is a mechanical symptoms, arthroscopy is a very useful technique. So to confirm the diagnosis and also to treat. Saucerization and stabilization by repair is indicated in unstable or in presence of a meniscal tear. Thank you.